So welcome everyone to the Center for Clinical Trials and Evidence Synthesis seminar. My name is Karen Robinson and I am delighted to introduce my friend and colleague, Wendy Bennett. Wendy has worked with the Evidence-Based Practice Center a few times. She's a glutton for punishment. It's kind of remarkable how much she's done with the center. So I very much appreciate her. As you might have heard in the side chat, Wendy is Associate Professor in the Division of General and Internal Medicine here at Hopkins. She has joint appointments in EPI and Population, Family, and Reproductive Health in the School of Public Health. She is the co-director for the Hopkins Center for Women's Health, Sex, and Gender Research, which crosses across the three schools, Public Health, Medicine, and Nursing. And she also is Director of Research for the Johns Hopkins Community Physicians, which is a community-based practice network. Her research focuses on obesity, type 2 diabetes, and cardiovascular disease, particularly among high-risk women. And today, you're going to hear about a pragmatic trial designed to test an intervention that she designed around health coaching for healthy lifestyle. So Wendy, take it away.
Sounds good. Yeah, well, great to be here. Nice to see lots of familiar faces, actually. And thanks for the lovely introduction, Karen, and invitation. And I would love to be able to take questions as we go, but have a hard time monitoring the chat, I think. So either Karen or Taylor, do you want to just let me know if you see a question? You can pause me and we can answer it as we go.
Yes, I can do that.
Definitely. Yep.
Okay, sounds good. So the title is a pragmatic clinical trial to limit gestational weight gain, and it's really an obesity prevention trial. And I'm going to be talking about our approach, which is around bridging the gap between trial, RCT, and clinical practice. So we're going to go over a little bit about the rationale and some of the evidence base for doing a pragmatic randomized controlled trial focused on limiting weight gain in pregnancy. I'm then going to share with you the study design of our funded trial that's promoting healthy gestational weight gain. I'm going to share with you some of the guidance that exists around doing pragmatic randomized controlled trials. And then I'm going to end with a series of slides just going through our particular design features and highlighting some of the challenges along the way for designing our pragmatic trial. And it's to test, you're going to see the name of our program come up, and I'm sharing it with you now so you're familiar. So it's testing a program called Healthy for Two, Healthy for You. That's the name of our intervention. So for those of you that are clinicians, which I think there's probably a handful of, I actually always like to sort of think about a case or a patient. Today's my patient day, actually, so I start seeing patients right after this. So this is a patient who highlights the epidemic of maternal obesity. She just had her third pregnancy. She delivered a baby boy who was healthy, 7.9 pounds. It was by cesarean delivery. She delivered at 36 weeks, which is a little bit early, but she had a lot of complications. So she had gestational diabetes, which is diabetes in pregnancy, very associated with obesity, but as well as other risk factors. She had mild preeclampsia, which is very high blood pressure and other complications, and that actually necessitated her early delivery at 36 weeks. And then she gained a lot of weight. So she had what we call excessive gestational weight gain, 34 pounds. She entered pregnancy already in the obese category with a body mass index greater than 30 at 37. And we know that she had Medicaid. She was Medicaid eligible during her pregnancy. Now most women continue to be eligible for Medicaid postpartum, which is great. So she'll continue postpartum, but she doesn't have any follow-up with a primary care provider, which is really something that I've done a lot of prior work on, is trying to hook women up with care after delivery when they've had complications. So we know that in the US, obesity disproportionately impacts women, and it particularly disproportionately impacts African American women. So this slide is from Flegel, who does all of these series from and Haynes, and we're looking at obesity among adults between 2005 and 2014. And if you look in the female category, you can see increasing rates of obesity in women. And then you also see that the rates are much, much higher for Black or African American women. So we know that there's a need to intervene on obesity. And one of the places where we can do this is in pregnancy. It's an opportunity for early intervention. And then maternal obesity has been identified as a cause for the increasing maternal morbidity as well as racial disparities. In 2015, over 50% of women entered pregnancy with overweight or obesity. We know that African American women are more likely to enter pregnancy with overweight or obesity, and then they're also at higher risk for gaining excess weight in pregnancy. Women who are overweight or who enter pregnancy overweight are at the highest risk overall of gaining too much weight in pregnancy. And why is maternal obesity and excess weight gain bad? So we know it's bad, particularly because if women gain too much weight in that first pregnancy or their second pregnancy, they have a hard time losing that weight after delivery, and it's a risk factor for future obesity. But it's also associated with a lot of pregnancy complications, like in our case, gestational diabetes and high blood pressure in pregnancy. And it's associated with chronic diseases. So obesity, we know, is associated with high blood pressure, diabetes. And there's some evidence that women who overgain in pregnancy have greater risk of having children who are obese. It's unclear all of the reasons. Obviously, environment is a big factor with that, but there is some concern about the intrauterine exposure to excess weight gain as well. So in 2009, the Institute of Medicine reevaluated weight gain guidelines. And for prior to 2009, there had actually been more concern that women might not be gaining enough in pregnancy. And there was a big focus on inadequate weight gain and nutrition in pregnancy. But in 2009, everything sort of shifted, and new recommendations that were actually purely based on expert opinion came out and gave these strata for how women should gain. So what's their recommended total weight gain range, depending on where they start. So if somebody, you can see, starts in the overweight category, that she should really be gaining 15 to 25 pounds. And anything above that is considered excess weight gain in pregnancy. One of our challenges has been that a lot of our pregnant patients start pregnancy with body mass index is much greater than 30, so in the 40 to 45 category. And there's actually not a lot of guidance on what they should be gaining. So since 2009, there have been many observational studies, and now I'll show you some of the large trials that have really validated these expert opinion recommended weight gain ranges. So these are now the weight gain ranges. Although they were developed because of expert opinion, they're really the ones that guide clinical practice. We did a study here using Xiaobin Wang, who's in population, family, and reproductive health, using her Boston birth cohort, which is a very diverse cohort with over 75% African American and Latino patients. And we looked to see if you gain inadequate versus adequate versus excess weight gain using those categories that I just showed you, what are your odds ratios for preeclampsia, gestational diabetes, and cesarean delivery? And you can see that excessive gestational weight gain puts you at greater risk for preeclampsia. For gestational diabetes, a little bit higher risk for cesarean delivery. Someone asked me yesterday about why there was a lower risk probably for cesarean delivery in those with inadequate weight gain. And it's probably because inadequate weight gain results in smaller infants. They're easier to deliver normally or vaginally, and so they're less likely to have cesarean delivery. But there have actually been many, many studies looking at these different weight gain categories and confirming these results. This study was particularly important because we were looking at a very diverse population, and prior studies had really been done in a mostly white population. And then the other thing that I want to highlight is that the number of pregnancies that women have with excess weight gain, these data are from the SWAN study, the study of women across the lifespan. And it's a large cohort study that follows women over many, many years. And that if a woman is gaining excess weight gain in multiple pregnancies, then she's not losing that weight necessarily easily postpartum, and it's putting her at risk for having a higher midlife BMI. And so this is highlights a lot of my work because as a general internist or primary care doctor, I'm really interested in early interventions to prevent obesity, and pregnancy and excess weight gain in pregnancy provide those early opportunities. So a lot of my work has focused on thinking about obesity prevention using a life course lens. And I've focused in on pregnancy as that opportunity. But there's all these chances around pregnancy. So preconception, which is prior to a woman getting pregnant, is a very difficult time to intervene because we often don't see women when they're contemplating pregnancy. We see them after the fact. But when we're able to intervene preconception, then we can reduce their risks of having obesity-related complications. I'm going to focus on some of our work done prenatal and postpartum. And then interconception is a term that's used in between pregnancy period. So if a woman delivers and then we know that she's going to have another pregnancy, so that period in between the two pregnancies is called interconception period. So what I want to highlight for you is that there's now a very large and strong evidence base supporting randomized, so supporting evidence around behavioral interventions. I'm going to share with you some of the behavioral interventions, but they're all well-designed randomized controlled trials now focused on whether limiting weight gain in pregnancy is effective in reducing pregnancy complications and in reducing overall weight gain in pregnancy. So this meta-analysis and systematic review was actually just completed, and it's in draft form still. So, and you can look at it on the ARC site if anybody's interested. And this was completed for the U.S. Preventive Services Task Force. So I think they're going to be hopefully reviewing it and making some recommendations about interventions in pregnancy to limit weight gain. So they identified that there were 64 trials, and depending on the outcome, they were able to do a lot of really nice meta-analyses. So we see that there's a decreased risk of gestational diabetes if you limit weight gain in pregnancy compared to controls. They did not show an effect on gestational hypertension or preeclampsia. There's evidence that limiting weight gain in pregnancy does reduce postpartum weight retention at 12 months, but not at 6 months. And then there are reduced outcomes related to the infant. So macrosomia are really big babies, or large for gestational age, also large infants. And those babies are harder to deliver and are associated with more complications. So you do have reduced risk of large babies, but there was no association on limiting weight gain with preterm birth or NICU admission. And I'm partly highlighting the NICU admission because payers care a lot about NICU admission. It's a big driver of cost. And if there are interventions that reduce NICU admission and reduce cost associated with birth, then payers are more likely to pay for those interventions and programs as they get implemented into practice. So I want to mostly, this is a very busy slide, obviously, and I don't want you to read all of these trials, but this is a really nice forest plot showing 33 trials that looked at the effect of having a wide range of behavioral interventions, so counseling on diet and exercise in pregnancy, and they show that the mean effect on weight gain is actually not huge. So it's about a 1 kilogram difference between intervention and control, and you can see that it is statistically significant, and so there's about a 1 kilogram difference, and that's really really what we're aiming for in these interventions. But 1 kilogram can make a difference, and it does make a difference for a lot of the clinical outcomes we care about, and potentially for women's risk of future obesity, since 1 kilogram in each pregnancy can really add up. So what are some of the counseling and behavioral interventions that we consider to promote healthy weight gain in pregnancy? So I highlighted that in the preconception period, these are non-pregnant women. They're coming in talking about something, oftentimes something unrelated to pregnancy, but we'll use a good screening question and say, are you intending to get pregnant? And if she says, yeah, I'm planning to get pregnant in the next year, and her BMI is 40, then we're often intervening at that point and talking about ways that we can reduce her risk of going into pregnancy with obesity, and oftentimes actually recommending bariatric surgery. So if she's willing to wait a year or two between having her surgery and getting pregnant, bariatric surgery will reduce her risks of gestational diabetes and other complications. And there is evidence supporting that. And then I mentioned that in pregnancy, there are many tested interventions, and they include behavioral counseling. So there's a wide range of different approaches. I'm going to share with you ours, which is health coaching. And then in practice, women are getting referred to nutrition services. However, it's really important to know that there have now been 3 or 4 pretty well done studies that show that very few OBGYNs are routinely counseling or even discussing weight gain goals with patients. And that when it's being done, sometimes it's inaccurate. So they're giving misinformation to their patients. And why is that? It's because OBGYNs are so busy. They are running from patient to patient. These visits are often 10 minutes long. Counseling about diet and exercise takes a lot of time. Setting goals takes a lot of time. And it's something that we're in medicine not very well trained to do. And so it's important to know that we need others besides our OBGYN providers to provide this counseling. And even though I showed you all of the different trials that have been done using counseling interventions, none of these programs have really been tested or integrated into routine prenatal care. And so that's where we started to think about and design our study. So the basis for our trial and also for our intervention design was the POWER trial. So this was a trial that was completed in about 2010. It was done here at Hopkins, and it was a weight loss study in non-pregnant adults. But what it was really important for was it was testing the difference between a control group versus, so it was 3-arm trial versus in-person support, which was really the standard of counseling, that patients had to come in and sit in group sessions and have in-person counseling, versus just providing support through the phone and web. And it was the first trial, and this was integrated into a care setting. It was a primary care integrated trial. It was the first trial that showed that remote support and in-person support were actually quite equivalent in terms of their effect on weight. And we know from some of our work that remote is very desired by pregnant women. They are busy, they have work, they have families, they're balancing a lot of competing demands, and they really want the remote delivery and the technology. And of course now with COVID, saying something's going to be remote doesn't sound bizarre at all, but of course several years ago we didn't do as much remote. So we took on doing some formative research to try to figure out how we would take an intervention like the POWER intervention, which was remote delivered counseling, and what would we do to make this more applicable to pregnancy. And we interviewed patients from OB practices as well as providers to inform intervention design. So these were patients from our practices who we interviewed, and we identified using a framework called the precede-proceed model, which looks at some of the predisposing factors, reinforcing factors, and enabling factors. What are some of the factors that we need to consider when we're designing this intervention? So women told us that they're really motivated to have a healthy baby, a healthy delivery, and they understand the importance of being healthy in pregnancy so that they can be healthy to take care of their infant. They also told us that they want support. So they said they don't just want inside support, but outside support, somebody who's going to support you, who's not just your provider, but they want people to support you. Like we had talked to them about what would it look like if they had a health coach, and they really liked that idea. They said that, they want to talk to their coach because their coach is going to know what's going on with them, and that they can ask their coach questions when their providers might not be able to answer all their questions. Their coaches would provide extra support. They also highlighted, I don't have quotes here describing that, but that they really wanted technology. But there's a lot of range in the ability of our patient population to interact with technology. Some people are really comfortable with it and others less. And so in designing any trial, we need to take that into account. So we designed our intervention, which we call Healthy for Two, Healthy for You, and conducted a feasibility and acceptability pilot study of this remotely delivered health coaching intervention to limit weight gain in pregnancy. We trained health coaches who were trained in motivational interviewing. For this pilot study, we had one study staff health coach, and then we actually had a Johns Hopkins Healthcare, that's our big insurer, provide a health coach from one of their health coaching programs. So we were looking at different models for where the health coaches might come from at that stage. We also designed web-based learning activities. So these are education activities focused on diet, exercise, and wellness. We heard from patients that they didn't just want to focus on their weight and their diet and exercise. They really wanted it to be about them overall, about their sleep, about their stress levels. And so we have a lot of modules focused on wellness. And then we also had them use a mobile app. Pretty much all behavioral interventions that focus on weight have a tracking component. So we're all familiar with various trackers probably on an app. We were interested in using something that's more off the shelf so that it can be adapted for our projects and not have to create something new just for the study. But women are able to use this to track their own weight, to track their diet. It gives us calorie estimates. And we designed a small study. So you can see it was a parallel arm trial, but it only involved 26 women. And we recruited from a single practice here at Hopkins and followed women from pregnancy all the way through 3 months after delivery. And what was also important is it gave us the opportunity to test out different recruitment strategies. So we integrated our recruitment into the initial prenatal visit, that very first visit that women have when they're pregnant. And what was important about that is it really gave us a glimpse of what this program could look like if it was further integrated into care. So we met with practices, we got a lot of feedback on how to do this, and it was a successful method for recruitment. So this shows you engagement with the Healthy for Two, Healthy for You program, which I'm abbreviating here as H42, H for You. So because it was parallel arm and 26 women, 13 women got the intervention, and the control was an education control we did. So you can see that we had really high rates of completion of learning activities. Those were those online activities, high rates of coach call completion. Women were tracking their weights. They were even giving us their daily calories. And exercise tracking was much, much lower. We have de-emphasized exercise for two reasons. One is pregnant women don't love to exercise. It's often hard and not fun, and something that they tell us they don't love doing. We also think it's hard to track. So it's not clear how much is lack of exercise and how much is not tracking. But there's also been a lot of studies emphasizing the importance of diet in pregnancy, where exercise is a piece of that, but not as emphasized. And then again, this is small, so we don't see anything statistically significant, but you can see the difference between the coaching arm at 37 weeks and the education control arm is, this is the median weight change. So it's about 9-pound difference, not statistically significant in this very small group. And then we looked at 3 months postpartum, and they're about the same in terms of their weight at 3 months postpartum. So this pilot study we published, and then we started looking for opportunities to get a full, well-powered study funded. And this opportunity came up. It's actually no longer an FOA, but had been for a few years before we applied. And it's called Pragmatic Research in Healthcare Settings to Improve Diabetes and Obesity Prevention and Care. It's sponsored by NIDDK. And we applied for this and resubmitted, and then it was funded. So our funding started just when everything shut down. So last March was when we first started working on the trial, and it's Healthy for Two, Healthy for You. Again, we abbreviate it often in this way, and it's a pragmatic randomized clinical trial to limit gestational weight gain and prevent obesity in the prenatal care setting. So I'm going to show you the study aims. So the first aims are effectiveness aims. We're testing the effectiveness of our program integrated into prenatal care compared with a usual care control among 380 pregnant and postpartum women who are enrolled from prenatal clinics. The primary outcome is looking at the difference in gestational weight gain between our intervention and control groups. So it's total weight gain, and we're looking from early pregnancy, less than 15 weeks gestation, the difference between their 37-week, which is the end of pregnancy weight, and their first pregnancy weight. So that's the total weight gain that we're looking at. And then we had a wide range of maternal as well as infant secondary outcomes. So the proportion who gain excessively using those IOM guidelines that I showed you. We're looking at gestational diabetes incidence. Postpartum weight retention is PPWR at 6 months after delivery. We're looking at infant birth weight as well as the infant's weight at 4 and 6 months. And then we have another range of outcomes that are focused on the psychosocial and behavioral aspects of the intervention. I want to show you our main hypothesis, which is that women in the intervention arm will have lower gestational weight gain and lower rates of gestational diabetes. And this will happen without an increase in low birth weight incomes, which is a safety concern. And that we'll be able to implement it successfully into prenatal care clinics, and it'll be feasible and scalable. So related to the feasibility and scalability, I actually just saw Emmanuel Drabo joined us. So he's helping a lot with this aim. He's in health policy and management, and this is focused on implementation. So we're looking at assessing the organizational factors that impact the implementation of the intervention into prenatal care, costs of intervention delivery, provider and staff satisfaction, and ultimately the goal here is to inform future dissemination. We're doing some qualitative work, asking providers and staff their perspectives. We want to make sure that we're addressing workflow barriers and enhancing the potential for sustainability. And then Emmanuel is leading us in a cost analysis to look at the ROI, the return on investment, by adding up all the intervention costs and looking at a wide range of different outcomes. So this is the overarching study design. We are screening using EPIC. I'm going to explain some of this to you in more detail. We are using that routine first prenatal visit as our opportunity for screening. We do an online and phone consent, which I'll also show you. We're aiming for 380 women. It's a very simple parallel arm design. They either get intervention or the usual care control, which we call MHIP, Maintain Health in Pregnancy. All of the participants are followed through delivery. Intervention goes through 3 months after delivery, but all participants are followed for 6-month outcomes. And we're using EPIC as well as a little bit of in-person data collection. I'm going to share that with you. So I want to highlight the rationale for a pragmatic trial. And actually, it was a long time ago in the 1960s that pragmatic trials, that terminology was coined because there was concern that many trials did not adequately inform clinical practice because they were optimized to determine efficacy, and that efficacy trials may overestimate benefits and underestimate potential harms. So we continue to be concerned about this, and pragmatic trials compared to what we call efficacy or explanatory trials are designed to study whether an intervention works in a real life condition. And ultimately, the idea of them is that they are aiming to inform clinical or policy decisions. So they're providing real world evidence for how we might adopt an intervention into real world clinical practice. So the guidance for pragmatic trials and what we still follow is the PRECIS, the Pragmatic Explanatory Continuum Indicator Summary. And they created these strict criteria initially and then kind of modified them and made them more flexible in 2015. But they provided a useful guide and scoring system, as well as this graphical representation to show how pragmatic a trial is based on all the different features. So these are the 9 domains from the PRECIS 2 tool. And you can see the key features. I'm not going to go into this in a lot of detail because I'm going to show you each of these domains and how it relates to our study and how we're designing the study with these in mind. But I just wanted to give you a glimpse of how they frame these in terms of recruitment, the intervention and its delivery, the nature of follow-up, and then the nature, determination, and analysis of outcomes. So we're going to go through each of the domains. And I just want to see, were there any questions so far? I'm happy to take questions if there are any. It doesn't look like the chat's getting populated.
No questions have come up in the chat, but if folks would like to unmute themselves.
Okay, I'll keep going and then people can ask questions at the end too.
Okay, thanks.
So the first domain that we think about is focused on both investigator and study participant selection and engagement. And PRECIS says we need to involve investigators who represent a mix of experience appropriate to the intervention under study. So for our study, we are involving many clinicians on our team of researchers. So we have OBs, we have nurse midwives, and then we are engaging the nurses who deliver care in all aspects of the study and in the design. And then we are also engaging our practice and operational leaders so that they can let us know what makes sense for workflows, for staff engagement, which meetings we should be attending, et cetera. This is extremely challenging, as you can imagine, especially with competing priorities. And with COVID-19, it's been even more challenging in clinical practices to get full engagement of all of our investigators who are busy clinicians, as well as to really involve all of the stakeholders. We have put together a stakeholder advisory board, and we are planning to meet with them soon, but they're going to be focused on implementation and sustainability ultimately. And so regarding participant eligibility, I wanted to highlight this, but it gives you a sense from typical efficacy studies, the typical ratio of patients identified and analyzed is actually quite low. So if we identified in an efficacy study 100 participants that are likely eligible for the study, they go through pre-screening, they're eventually consented, randomized, and analyzed, it actually ends up only being about 7% of participants. And we all look at, the typical consort flows all the time, and sometimes it's even less than that. So the idea in pragmatic studies is that you want to design your recruitment strategy so that you make it more welcoming and you broaden your participant eligibility criteria. So our eligibility criteria is trying to emulate who would be receiving this intervention if it was part of usual care. So the major inclusions is we are targeting women who are adults. We are looking at women who enter pregnancy with overweight and obese, which in our patient population is more than 60% of patients. They have to be pregnant with a singleton pregnancy, which means one fetus. And then we are getting most of our data from the electronic health record, which here at Hopkins is EPIC. And so we have broadened the eligibility. They need to have a weight in EPIC prior to 15 weeks gestation to be eligible. And then right now we only are recruiting English speakers, and that is partly because all of our web-based materials and our coaches everything is in English, but we're really interested in eventually adapting it all for the Latinx population here in Baltimore, because there's a very high need for work in that area as well. The major exclusions that we've considered are where is it where pregnant women require a special diet or special activity recommendations, or might need very intensive monitoring, making it harder for them to participate in a lifestyle intervention in pregnancy. And so that's what we're listing here is women who have type 1 or type 2 diabetes, a history of a very preterm birth, very high blood pressure, if they're really unable to walk because they are short of breath or in a lot of pain, or if they have multiple fetuses because then they need a lot more monitoring in pregnancy. So looking at domain number 2, looking at the recruitment process and consent process, there's actually been a lot of debate about whether you even need the same consent for pragmatic trials. And depending on the study, I think there can be a lot of variation in the consent process. But the question is, how much effort is made to recruit participants above and beyond what you would normally do in usual care to engage with patients? So we've designed a recruitment process that is to emulate the real world clinical program, if this was a clinical program. So we are building something called a best practice advisory, BPA, that pops up during a early prenatal visit, and the nurses can interact with this. And after it fires based on eligibility criteria, the nurses can click accept, and it comes immediately to our study team. So we are able to review a list of patients that have been referred to us. We're actually able to review anytime this pops up, so whether it's acted on or not. And we have IRB approval that those where it's where we didn't actually get that it was accepted or acted on, that we can screen those patients and send them a message in my chart to see if they are interested. But for those where the nurse acts on it, we have trained the nurses in clinic to provide a little bit of a blurb about what the study's about. We're doing a research study called Healthy for Two, Healthy for You. You might be interested in this. It's on lifestyle management and pregnancy. Would you be interested in if the study team was to call you? So it's very brief. And then if the patient says yes, that comes to us. The study team, like in other trials, will then further evaluate eligibility criteria. We use EPIC for that. And if a patient continues to be eligible, then pretty quickly, I was just telling the team this yesterday, that hopefully all within like 24, 48 hours, we can then call the patient, confirm that she's interested, and then randomize her. And that is our enrollment process. We're also doing a consent process that is phone facilitated. So it's an electronic consent, and we built this into REDCap. These are 2 images from it, but there's actually a lot more on the consent form that flows through. But REDCap has a really nice method for doing electronic consent, and patients are able to sign in EPIC. They can also download our full consent form. So the next 2 domains for PRECIS are domains 3 and 4, looking at setting and organization. And the questions that they ask is, how different are the settings of the trial from the usual care setting? How different are the resources, provider expertise, and the organization of the care delivery in the intervention arm of the trial from those that are available in usual care? So the ideal setting to do pragmatic trials is what we call the learning healthcare system. And we are still learning and building this here at Hopkins in so many ways. So the idea is that the learning healthcare system would have a redesigned so that all of the data that we're collecting that's relevant and all the patient-reported data could also be useful for research. So it would have this default in it. And we don't quite have that yet. So we're still trying to figure out, how do we benefit from our healthcare system and leverage it for research. And the other challenge is really around feasibility. So clinical delivery pressures, especially with today's complicated healthcare system, there's multiple priorities. When we talk to our providers about weight gain and pregnancy, they say, we have so many other priorities right now. Weight gain is important, but we're also talking about domestic violence, and our patients have many complications and social determinant barriers. And there's so many factors that providers are considering when they're taking care of patients. And so this is sort of the balance that we have to strike with trials like this. We have engaged a lot of clinical sites, so we are benefiting from partnership with Johns Hopkins community physicians. There are 2 practices here in Baltimore City, Canton and Remington. One of the Johns Hopkins community physician practices at East Baltimore Medical Center was just taken over and is now being run by Baltimore Medical Systems, which is a FQHC. And so now we are partnering with Baltimore Medical Systems as well. We are also benefiting from 2 academic partners here at Hopkins, our Bayview practice, which has another practice out in White Marsh, which is a little bit more of a community setting. And then here at Hopkins Hospital, Nelson 2 and Jayhawk. So I want to talk about domains 5 and 6, which highlight the intervention and the way we're delivering the intervention. So the idea of the intervention, and this is really specified actually in the FOA, is that the intervention needs to be delivered as if it's normal practice by normal everyday staff who have typical experience. And the idea is that they're not supposed to be outside of the healthcare system. In fact, what has been most challenging is that the NIH has actually required as part of this that we cannot pay our intervention staff at all. So they need to be part of the embedded in and part of the healthcare system and delivering the intervention as part of their regular jobs. And they cannot be getting paid above and beyond for the work that they're doing. So we have to look at the flexibility in how the intervention is delivered and whether this flexibility is what we would anticipate in usual care. And also in how participants are monitored and encouraged to adhere. Do we go above and beyond to help them adhere to the intervention, or is this what routine care would be? And what's most challenging about our intervention is that right now, our health coaches, so I mentioned this is a health coaching study, and now we're training existing staff to be health coaches, but health coaches are not part of the healthcare system right now. There are no clinics that say, oh, here's your doctor and here's your health coach, or come meet your health coach tomorrow at a group session. So we, at the same time that we're building this intervention, we're making an argument for the healthcare system and for our clinics that health coaches are important and that health coaching could be part of what their providers are already doing, and it could fit into their workflows. And so this is the most challenging part of this intervention design. So we are recruiting health coaches to be part of our study. They receive training, but they are not interventionists. They are really part of the care team. And they do all their coaching by phone. Patients also are participants, once they're in our trial, are also given access to our interactive web-based program, and then they also will use a mobile app. Right now we're using Fitbit so that they can track their weight. It's the Fitbit app, so we're not giving people the wristwatch Fitbit, but it's the Fitbit app that they'll be using. We have designed a very beautiful, thanks to Lindsay Martin, who is my research manager and tech whiz at programming, this web-based platform using a model that our team developed called the COACH model, which stands for commit, omit, add, communicate, and honor your wellness. And using that model, we then have all different learning activities. This shows you the first 7 of them, which are our core learning activities in the program. And one of our challenges was actually that we were using an outside vendor to build this web-based platform. And with COVID-19, they ended up getting a Department of Defense contract to work on COVID-19 related work, and they had no time to work on our program. So we have redesigned this entire platform now using REDCap. So we are using that within Hopkins, and it's a really novel use of REDCap if anybody's interested in seeing our platform. It shows you all the learning activities. As I said, there's 7 that are our core content, and then there's 19 in total. Some of them are postpartum, but it gives you a sense of all the different activities we've designed. So for domain 7, it's about how are we following up our participants? How are we doing data collection? And how are we assessing outcomes? And what the PRECIS domain says is that we have to use unobtrusive data collection of trial outcomes to reduce participant burden without introducing artificial aspects to follow up. So this is challenging in all research. We all want to minimize burden, but we know how hard it is to do that. So we're using all web-based forms. We're using REDCap for our surveys. These forms can be completed at home. We've tried to reduce the number of them so that we can minimize time burden. The surveys are above and beyond what patients would do in routine clinical care. In other projects that I've done, we've had surveys embedded into MyChart, and I think that that's a really nice way to go. Getting data out of MyChart is more challenging than data out of REDCap, however. And then all of our data collection has been designed that it's coming from the electronic health record. So it's coming from Epic. So we are collecting clinical data, safety data, and avoiding the need for additional study visits outside of routine care. We also have alerts using CRMS for when somebody has a hospitalization, but we're also creating a system where we have this constant flow of data from Epic, and we can assess when a prenatal visit is missed, because that's when we're getting our outcomes. So if they're missing a lot of visits, we need to know about it, and then that might mean that we reach out to the patient to either get them in for care, which is clearly needed, or even to follow them up with a wait somewhere else at home. Real world data collection is tricky because we want the quality to be high. And there's a lot of different ways that clinics can get weight and height. Sometimes they just ask a patient, how tall are you? And so we're doing a training in all of the clinics. We're calibrating scales. We're doing this refresh that we call it, to have them be trained to ask patients to take their jackets off, to take their boots off, so that we're getting weights that are as accurate as possible in Epic. And then for the postpartum weights, women are no longer going to be coming in for their prenatal visits. They're going to be after delivery. So we are partnering with the pediatric practices, and we've created a protocol where the patients will be able to get on the scale at the pediatric visits, and they'll have a REDCap link. So if once they're weighed and the medical assistant tells them their weight, they'll tell us the weight through REDCap. We're also abstracting information from Epic for infant outcomes. Particularly, we're interested in growth outcomes like weight, height, and head circumference. I wanted to highlight all the ways that we're leveraging the EHR. So again, we're recruiting using the EHR. We also have a provider referral that we've created in addition to the best practice advisory. We're creating this pretty much daily flow of data that goes from Epic into a Sequel database that our study team is then able to query. We're using CRMS, which is the system at Hopkins that will allow us to get alerts when patients are admitted to the hospital or go to the emergency room. So it gives us safety surveillance in real time. This is not a high risk study, but these are pregnant women, and there is a requirement for us to monitor their safety as part of their trial participation. We're also assessing whether data collection is happening, as I mentioned. So are these weights occurring, and when are we missing weights? And then for intervention delivery, we're flagging patients who are in the intervention group, so providers can see who's in there, who they will know that somebody's receiving the program, so that they can cheerlead for them and say, oh, you're doing great, and talk to them a little bit more about the program. And we're also sending them progress reports. So for domains 8 and 9, these are the last two domains. It's really trying to understand which endpoint should we be measuring? Are they important to patients? And are we making sure that we include all possible data? The good thing about using Epic is that we think we're going to have fairly complete data unless somebody delivers preterm, but then we will have all the wait time points before that. There is concern for us about missing data postpartum, and that is something that we're trying to reduce so that we have fewer missed waits in the after delivery time period. And then I think I saw Nayu Wang join. So Nayu is our biostatistician and has designed our analysis. So we're using standard analytic approaches, ITT analysis, and a mixed effect model to assess between group differences. And again, the main outcome is total gestational weight gain, which is important to patients. So patients do care about their weight in pregnancy, and they don't want to overgain, and they want to be able to lose weight after delivery. So it is a patient important outcome. So some of our challenges, so I've highlighted a lot of challenges, and I'm just going to summarize them here. So the biggest ones are really just keeping everyone engaged. Clinics are busy, staff is busy, they have other priorities. We're trying to identify our health coaches, we're trying to keep them engaged. We're trying to balance our workflows of clinical care with health coaching roles, the nurse-led recruitment process. We've designed this flexible web-based platform, but we need to design it so that all patient populations can find it useful in terms of education levels, health literacy levels, as well as technology abilities. We're trying to create models for what this program might look like if it was really a clinical program. If it was reimbursed by Medicaid, what would it look like? And then we're trying to build our research team. So the research team we have discovered, really needs to understand how clinic works and how the electronic health record works. And getting them in front of our clinicians as much as possible is important. We are very close to launch. We're running a little late. We're planning to launch in the next 2 weeks. We're recruiting for 3 years. And so this is our team. I want to just highlight, we have lots of hard workers. We're a growing team, and we have lots of OBGYN co-investigators. I saw a lot of my team join today, so thanks everyone who joined to support. And we just have this amazing group of people, and we are hiring. So unfortunately, Rachel Sanders, who I saw was joining us, well, fortunate for her, unfortunate for us, but she accepted a PhD program position at the University of Pittsburgh. And so we are looking for a new project coordinator. So if anybody knows somebody looking, feel free to reach out to me, because hiring from within Hopkins is so much easier. So I want to see if there are any questions, and I can go back to slides, but thank you so much for having me. This was really a great opportunity.
So, Wendy, thank you very much. Really, it's an outstanding talk. I have a question for you about your consent procedures and how they influence your sort of goal of recruiting broadly. If you're doing online consent, you obviously are restricting to people with computer access. And the second piece of that is, if you're using MyChart, at least early on, the uptake on MyChart was less than universal. So you are also restricting further to those who are computer savvy, or more computer savvy, relatively more computer savvy. So I wondered, what are you doing in terms of your consent procedures, and does that restriction worry you about the broad representational nature that you're looking for in a pragmatic trial?
Yeah, I think that's a great question. So a couple of things. One is in young women, so these are women, generally under the age of 35, phone and smartphone use is pretty ubiquitous. Everybody has a smartphone, and we have done a lot of research looking at that in our population. Where it drops off a little bit is actually in our Latinx population here in Baltimore. There are people that still have flip phones, and there's some shared phones in families. but many women of all different socioeconomic levels have mobile phones. So we're relying on mobile phone usage for them to be able to view the consent form. The phone, so we're doing this, it's a phone, it's kind of a hybrid of electronic consent. So they'll be able to have this up in front of them and also talk through the consent process by phone with one of our study staff. So it's not only e-consent. And then we also are IRB approved to do in-person consent. So if somebody is really struggling with computer access, or it just makes more sense for us to meet them in clinic, then we will do the consent at the time of their clinic visit, and we could do that in person using paper and using the sort of old-fashioned way. It's interesting. So many studies have gone to electronic consent during COVID-19, and we have been using e-consent for many, many studies now. This is our third study where we've used electronic consent, and it's actually been extremely successful. We find that patients can figure it out pretty easily. We're also using REDCap for this process, but also REDCap for all of our surveys. So there'll be a little bit of a training for all of our participants on using REDCap, because REDCap is how we're getting pretty much all of our surveys completed. So we're hopeful that because they have mobile phones, that they're going to be able to go through this consent and talk to our study staff who will walk through it with them and be able to reflect a little bit on their understanding of the study.
Are you going through my chart, or does your mobile consent bypass my chart?
So we're not using my chart for this. It's all of the electronic stuff is all through REDCap.
Mm-hmm.
Thank you, Wendy. That was really great. And I have a lot of questions, but I did want to thank you for accepting my invitation and coming today. And I know people will probably drop off as they need to, but I have one quick question. I was interested in the use of the Fitbit app. And are you seeing the data that the women are entering on the app as part of the intervention? So part of tracking your calories and so forth? Or are you going to somehow use this data as well?
Yeah, so that is a really, really good question, Karen, and that's actually been an issue recently for the team. So ideally, we would love to be able to get all of the diet, exercise, and weight data from Fitbit and have that constantly flowing in and be able to intervene on that. There is a tool to do that right now called Fitabase. So it is a cloud server that integrates the Fitbit data from your participants. It's fairly expensive, and then it still requires a lot of data manipulation. So we have made the decision in part because our coaches are medical assistants, dietitians, and nurses, and are not going to be able to really be able to interpret all of that data, that we are using Fitbit more as a trigger for conversation, as a tool to understand how they're doing with tracking and with their diet, and as a way to reflect with their coach. But we're not going to be viewing every entry of data with them. We are doing some other tracking besides Fitbit. So we're going to be sending all of our participants in the intervention group a weekly, they're getting scales at home to monitor their weight at home. So we're asking them to get on the scale once a week, and they're going to get an email with a REDCap link to give us their weight every week, and we will have all of their weights. And the other way we're going to use Fitbit, so we're also not sure how much people will use Fitbit. In our prior studies, women that were most motivated and with the highest SES were the ones that were most likely to be faithful using Fitbit and use it regularly. And so we're using it also as a tool to kind of augment monitoring and tracking when women's weights are not tracking where they should be. So it's a way to sort of step up the intervention. And although this is not an adaptive design, we do have the ability to kind of increase, like kind of dial up and dial down within the intervention, how much we're doing. We're offering some group sessions for people that are struggling. We're also going to do some more intensive monitoring using Fitbit for those that are struggling. And there are ways in Fitbit to friend. So you could like friend your coach, and then the coach can see your data. So we're doing that selectively. But we made this decision that it probably, for this pragmatic trial was not going to be worth the effort it will take to synthesize all of this huge amount of data from Database. So we've actually gone back and forth a fair bit on this, on whether we're going to try to do that as sort of an intervention tool or not. So for now, we're actually not doing it.
Great, thanks. Janet, did you want to ask your question? I saw just pop up. Janet?
Yeah, I can read her question. So it's about, can I talk about the control group? So we have a usual care control. They are, so it's interesting about the Hawthorne effect. And that's your question. Will the Hawthorne effect, impact our participants? Will they be more likely to change behaviors? So what the control group is getting is they're getting their standard of care, they're getting their prenatal visits, they are getting all the same data collection, so they're going to be getting surveys from us, and then they are invited to participate in their own Facebook chat page, and we are doing content for that is not focused on what the intervention is focused on. So there's not a lot about weight management. There's nothing about sort of diet beyond just kind of like staying, like we have some of the content about staying away from foods that are unsafe in pregnancy, like unpasteurized cheese, for instance, but it's not focused on weight management per se. So we think that there probably won't be much benefit or behavior change in the control group, in part because it takes a fairly intensive intervention for people to really be motivated to change their behaviors. And most weight loss studies have shown that the control group, even if they're, even if they're monitored more closely than ours, they need that intensive, support from a coach or a counselor in order to make significant behavior changes that are really going to change their weight. So, but that's the strength of doing the randomized controlled trial, right? So even if there is some change, we'll still be able to hopefully detect what that is and be able to look for a difference.
Any other questions? I know I'm conscious of time here.
Yeah, I went right up until 9:25, so.
I had a quick question. My name is Divakar Mohan and I'm from the School of Public Health. So if the intervention is quite intensive, as you say it is, then how difficult or easy will it be to kind of scale it up to the general population? I'm kind of referring to like beyond the trial setting, how easy will it be to kind of make it practice?
Yeah, so that is exactly what our team is considering. And there is a growing literature about health coaching programs in general. So there's sort of a few different flavors where people will encounter health coaching programs similar to ours. So one is actually through their employer. So you can imagine like Johns Hopkins wants to retain pregnant women, wants them to come back to work, and can provide health coaching during pregnancy to support them in their pregnancy. And there's actually some models out there for doing this where it's an employer purchased program and they deliver health coaching. It's not linked with care then, right? So it's a health coaching program, but it's paid for by the employer. And there's several models like that for the employer giving that to their through HR, right? The other model that we are most interested in is what would it look like for Medicaid to cover this? And because of the strong interest now in population health, there is a model, and actually many of the Medicaid providers in our state do already have health coaching programs. So they have health coaching for smoking cessation, they have health coaching for weight loss, they have health coaching. There is one at Johns Hopkins already for health coaching to help monitor weight gain in pregnancy, although it's very, very tiny and it's not evidence-based. But we're hoping that we can make an argument for that this can be integrated into care, there's benefit, and then it could be covered by insurance companies. But if not, it could become something that Medicaid picks up and is now providing as a population health program that they're providing to their to people that are insured by that Medicaid product. So there's a number of different models. I think we are testing the most challenging model. So we are testing, can our staff in clinic coach their own patients, and the challenge there is really around time and all of the barriers around workflows. So these are not sort of devoted coaches that the Medicaid program might hire or partner with as sort of a subcontract. These are providers who are not trained as coaches, and we're training them on this special role. And so we want to show that it can be integrated, but I do think that we have sort of the most challenging model we're testing. Does that answer your question?
Thank you. Thank you.
Sure.
Great, I think probably we need to end there, Kaylor.